to be with you once again in the Satellite Symposium of AstraZeneca, and I have the pleasure to have with me Professor Ala Andil, Professor of Clinical Oncology, Alexandria University, and we have a very eminent speaker, Professor David Cameron. Professor Ala will present to you Professor David Cameron. Please.
I'm glad and honored to present Professor David Cameron, Professor of Oncology at the University of Edinburgh, and at the same time Director of Cancer Services at the NHS, National Health Services. Professor David Cameron is a very well-known figure in the field of medical oncology, and right now he's the Director of NIHR-funded National Cancer Research Networks, and still continues as an Associate Director. Dr. Cameron, the floor is yours.
Thank you very much for those kind words of invitation. Thank you for inviting me not only to be here in Egypt and at this conference, but to give this talk. What I plan to do is to try and discuss where there is a role for fulvestrant in the endocrine treatment of breast cancer, to help you try and see how I, based on the data we have, can see where this is an important option for some of our patients with breast cancer. So first, let me just rehearse the important principles that we need to keep in mind when we choose to give a woman with breast cancer endocrine therapy. I will not be discussing the more complex situation of the male breast cancer patient, where the data are fewer. This is really focused on women. And the first important thing is that we need to select patients whose breast cancers express hormone receptors, and primarily the estrogen receptor. Now, in Western Europe and the US, maybe 3/4 of the women have hormone receptor positive breast cancer. In other parts of the world, the proportion may be slightly different, but this is a really important driver. It's a predictive factor for sensitivity to endocrine therapy. And those patients who have very high levels of estrogen receptor in their breast cancer have a high chance of responding. Those with lower levels have a lower chance. It's not nil, but they are less likely to respond. And in managing advanced breast cancer with hormone therapy, I think a critical question is to say, is this woman, is her breast cancer going to benefit from endocrine therapy? It's always a guess. We never know for certain till we try, but it's an important question we ask at each stage for selecting endocrine therapy. And for lower ER, it is less likely, not unlikely. And if we look in the adjuvant setting, these are old data, but they're important, you can see that those patients selected for endocrine therapy on the basis of positive estrogen receptor have a much better outcome. And if you drill that down, looking at the level of ER, you can see that those with 0, and this is the ORID, or quick score of method, those with a score of 2, which means less than 1% of breast cancer cells have only a low level of receptor expression. They don't do any better than those with absolutely none. I don't have a pointer, but you can see that as the number goes up on the right-hand side, which indicates more and more of the breast cancer cells express the estrogen receptor, the better those patients do in the adjuvant setting treated with tamoxifen. But in the metastatic setting, we do not have quite such comprehensive data sets looking at the actual level of estrogen receptor. What we do have is another important signal. So I have taken data from a first-line trial with letrozole, but it could be any of the aromatase inhibitors. And the thing you need to notice is that about 1/4 of those patients progress very quickly. They had estrogen receptor, so they were ER-positive breast cancer patients. Thank you very much. But you see here that very rapidly they progress. And this is a common finding in endocrine therapy studies, that there is a subgroup who progress rapidly. Who they are is what I will now spend a few minutes talking about, but with every patient we never know until we actually try. And the other important thing to think about endocrine therapy is when we talk about sensitivity, That is not the same as response in the cancer. Many of our patients we treat with endocrine therapy with advanced breast cancer, we may not see their cancers shrink. But if we stop the cancers growing, i.e. we cause stable disease, provided we do that for many months, that is also something worth having. And this is an interesting analysis from Professor John Robertson in the UK. The numbers are small. It's only a few hundred patients, you can see on the bottom. But what he showed was that those women whose cancers actually had a confirmed response, whether to anastrozole or, for the less young in the audience, a drug we used to use called Megace, a progestogen, if they responded, that was their survival. But if they didn't respond, but did not grow for at least 6 months, and so had stable disease for 6 months, in yellow, their survival was exactly the same. So, stopping a cancer growing with endocrine therapy, particularly in a patient with few or no symptoms, is a worthwhile goal. It looks like her survival will be just as good as those patients whose cancers actually shrink. Clearly, if they progress, or they're only stable for a few weeks, that is what we mean by patients whose cancers don't respond. And please bear that in mind. So I'm not talking about response shrinkage. I mean response in the sense that this cancer, its behavior is altered by endocrine therapy, either by stopping growing or by actually shrinking. And the other really important thing to remember about endocrine therapy, which we will all have seen in our clinics, and this is again based on old observations, a cancer that responds to one endocrine therapy is more likely to respond to another one. Once a cancer stops responding to endocrine therapy, yes, it may respond to another one, but they become less sensitive. And again, by response, I mean benefit, not just actual shrinkage. So this is data from about 10 years ago, but there are older data that those patients on second-line endocrine therapy who had benefit were much more likely to benefit from the next therapy and the next and the next. Whereas those who didn't benefit on one endocrine therapy, then you see their chance of benefiting is smaller. So stable disease and response is what you want to see. If you see it on one line of endocrine therapy, it's more likely to go through onto the next one. So how do we select? Firstly, they need to have endocrine receptors in their cancer. Most of the time, it's from the primary. We increasingly rebiopsy metastatic disease because the receptors may change. If you can't get a rebiopsy, and in many patients that is difficult, presence of receptors on the primary is important. And to me, the most important receptor is the estrogen receptor. There are a few cases which are estrogen receptor negative, progesterone receptor positive, but it does seem to be a very small group. They do seem to benefit as well. But the other factors that matter are how the cancer has behaved. So in the metastatic setting, the patient had had a prior diagnosis and treatment. The longer the time between their first diagnosis and their second diagnosis, especially if they've been treated with adjuvant endocrine therapy, the more likely they are to be endocrine sensitive. As mentioned already, sensitivity to previous endocrine therapy is also important. But what about sites of disease? There has been a view that if a patient has visceral, lung, liver metastases, then her cancer is not endocrine sensitive. Whereas if it's soft tissue, skin, lymph node, and or bone, then we see that as endocrine sensitive. How true really is this? So this is some data John Robertson again presented last month in San Antonio, meta-analyzing data from some first-line endocrine therapy studies with either fulvestrant at 250, and we'll come back to the question of dose later, or anastrozole or exemestane. And it's slightly complicated, but let me show you the important things. 55% of women in these studies did not have visceral metastases. Their overall benefit rate varied from study to study, but about 2/3 of those women with non-visceral metastases clearly benefited from the endocrine therapy in these studies. 45% of the women had visceral metastases in these trials of first-line endocrine therapy. And their overall clinical benefit rate, very similar. And there are other studies, smaller in number. The advantage of this analysis from John Robertson is the size, with several hundred patients. So women with visceral metastases can respond to endocrine therapy if they have endocrine-sensitive disease. And there are situations where we don't have time to test the endocrine therapy. Please remember, endocrine therapy always works more slowly than chemotherapy. So one of the reasons we talk about a visceral crisis is that it's a crisis of time. If somebody is sick, severely deranged liver function tests, getting worse by the week, we don't have time to see if hormone therapy works. If she's fit enough for chemo, however gentle, then chemo is what you need. But a patient may have liver disease, and I distinctly remember a case like this myself. We diagnosed her with metastatic breast cancer in the liver. But when you took her history, she had been knocking on the doors of various doctors for nearly 9 months with the same symptoms, slowly getting worse. She'd had visceral metastases for 9 months with no treatment. So we gave her endocrine therapy, and it took its time, but it responded. So visceral disease can respond, provided the patients are not in crisis. So we can end up, and I'm grateful for someone else for this slide, we can end up with a sort of rough classification. Highly sensitive endocrine disease, especially those who've never had endocrine therapy before, provided they're ER positive, or they've progressed well after finishing adjuvant endocrine therapy. So if they've had 5 years, then they progress at least 6 years after diagnosis. If you've given them extended therapy, it's at least a year after finishing it. On the other extreme, we have the least sensitive group, particularly if they're going into second and third line, because the response does get lower over time. These are particularly women who've progressed during the first year or two of adjuvant endocrine therapy. They've probably had little benefit. We gave it to them, but it progressed rapidly. Or we tested prior endocrine therapy for metastatic disease, and it didn't work. They were in that waterfall, that rapid fall off in the trial I showed you. Or a very complicated clinical case, visceral crisis or something like that. But a lot of the patients we actually see sit in this middle group. They progressed either on endocrine therapy or within 12 months of stopping, but not in the first 2 years. They progress at year 4, year 5, year 6. They've had benefit from prior therapy. Yeah, I have a medium chance of responding. So we can sort of think about this in 3 places. On to fulvestrant. So this is a cartoon showing you the chemical structure. I'm not a chemist. I don't understand the details. But the important thing to notice, that's what estradiol looks like, and that's what we're trying to stop driving estrogen receptor-driven signaling. And fulvestrant is based essentially on the same molecule. It's a steroidal molecule with a long chain, which means it then behaves differently when it gets in the cell. Tamoxifen is quite different, and raloxifene, another drug which is also used but not in breast cancer treatment, is again chemically very different. And the non-steroidal aromatase inhibitors are similarly different, whereas exemestane, a steroidal, is more like these two. So how do these drugs work? I suspect most of you know this, but we'll take it through briefly, because at the very end there's a reason why the mechanism might be important in the future. So estradiol binds to the estrogen receptor at the AF1 end. 2 receptors get together. Classic phenomenon, we see it in HER2 as well, activating the receptor, which then drives transcription in the cell. Tamoxifen blocks that interaction at the AF1 end, inhibiting and preventing the dimerization because AF2 is not activated, and so you get reduced but not absent transcription. Obviously, the aromatase inhibitors stop estrogen doing this. That's how they work. So they don't work at the level of the ER. They work on the woman to stop estrogen getting to the ER and activating it. Fulvestrant binds to the estrogen receptor, but there is no dimerization. There's no switch on of the estrogen receptor. There should be no transcription. And what in fact happens is you see accelerated destruction of the receptor. It turns out that estrogen receptor is always being turned over. Proteins are not stable in cells. They're made and they're got rid of in a very carefully managed process. What fulvestrant does is to accelerate the destruction. So the receptor's made and then disappears. So it's not there to bind to estrogen. So it's an antagonist with no agonist effects. It's known as a SERD, a selective estrogen receptor downregulator. It's the only one out there now, but there are others being developed, both by AstraZeneca and other companies. So this is a space to watch for the future. And it's not an aromatase inhibitor. It has a slow absorption. It's given by intramuscular injection. The slide is out of date because it says 250, I just realized, but that should be 500. Dosing matters. Takes months to get to steady state with monthly dosing. Long half-life, mostly protein bind, a large volume of distribution, and metabolized differently to the aromatase inhibitors with fecal excretion. Now, this is an old study, but I want to show it because it illustrates perhaps why we started using fulvestrant at the wrong dose. So this was a single-dose study, biopsying patients at diagnosis and then after 2 weeks treatment. Low dose, slightly higher dose, what used to be the standard dose, and the comparator arm was tamoxifen and a placebo. Again, from John Robertson, who's done an awful lot to help get this drug have its clinical efficacy demonstrated. And what you can see here is this is measuring the level of estrogen receptor, because if the drug works, there should be less estrogen receptor having been treated because the destruction is accelerated. Placebo, essentially the same. Small dose of fulvestrant, it drops, and as the dose goes up, we see less and less estrogen receptor. And for control, tamoxifen is put in, which causes some loss of estrogen receptor. Now, that used to be the dose, and that was the highest dose used in this trial. One wonders, had they continued to increase the dose, whether we'd have seen more and more effects at higher doses. Those dots are made up. We don't know the downregulation effect of the higher doses. And the highest dose that I'm aware of given to a patient was in fact 750 milligrams in a study in premenopausal women. It's not licensed in that group. We don't understand the long-term effects. But even in premenopausal women, it did cause some ER downregulation. And what then happened was 2 pivotal phase 3 trials were run, one in the US and one in Europe, randomizing against anastrozole. And this is the US trial, very similar design. The demographics are slightly different. So in this study, you can see that up to a quarter of the patients, or at least up to a fifth of the patients, either had unknown or clearly negative ER-PR status. They should not have gone in the trial. And they weaken any conclusion because they essentially don't respond to either arm. The US trial had a slightly lower proportion, maybe up to about 10%, but even still, that was how we used to do trials, and I think we have learned to leave those patients out. If you look at the activity, the biggest difference in the European trial was in favor of stable disease for anastrozole, but I want you to look at this bit over here. There was a difference in complete responses, and they're not common in endocrine therapy. We did see slightly more with fulvestrant. In the US trial, the stable disease was in the opposite direction, but again, some complete responses, possibly slightly more on fulvestrant. So the drug is working in terms of response similarly to anastrozole. If you combine the 2 trials and look at time to progression, there was no statistical difference for fulvestrant at 250, but that's not what we use anymore, and I'll come to that next. If anything, it was marginally in favor of fulvestrant, but it wasn't significant. So it was as good as anastrozole at what turns out to be the wrong dose. In terms of objective response and clinical benefit, even in this study with visceral disease, you can see that the drug was active, and in patients with visceral disease only, it was similarly active. So visceral and non-visceral responded essentially similarly to anastrozole and fulvestrant. And the duration of response is shown here. In the US trial, it was significantly longer for the fulvestrant. So once you'd responded to fulvestrant compared to anastrozole, your disease was controlled for longer. And overall, there's a suggestion that those who did respond did slightly better on fulvestrant, but it wasn't really significant. So essentially equivalent in that setting. Tolerability is important. This is a summary of the side effects. In that analysis, there was an impression that fulvestrant caused less problems with joint pains, which we often see with endocrine therapy. That hasn't held up in other studies, but it's certainly not worse. And probably one of the most important factors in any trial is to look at this. How many women simply came to their doctor and said, I can't stand it. This drug is causing a toxicity I don't like. And the answer was, really no difference. Very few women on either arm. Now, we know how well aromatase inhibitors are tolerated. They're not perfect, but they're reasonably well tolerated. Fulvestrant turns out to be essentially as good, with some differences in side effects. And that's important when you think of where we're heading in the future. 2 large trials were conducted. I was involved with Steve Johnson in the bottom one, the SOVIA trial, in the second-line setting, in patients who had prior non-steroidal aromatase inhibitor compared to exemestane, which was then essentially our standard. The SOPHIA trial had a third arm which combined the 2 drugs, and that showed no advantage. So I'm really going to focus on these 4, that's over 1,000 patients randomized between 250 of fulvestrant, although it had an accelerated loading, plus or against exemestane. And the answer was they're as good as each other. The median progression-free survival for both drugs was just under 4 months. But the CONFIRM trial confirmed that we've been using the wrong dose. We should have been using 500. And the CONFIRM trial is very important because it compared the 250, which is what was licensed then and we've been using in much of the world, against twice the dose at 500. And you can see very clearly in progression-free survival and in overall survival that 500 is significantly more active. So having said to you it looked as good as anastrozole, that was at the lower dose. Having said to you it was equivalent to exemestane, it was at the lower dose. So although we do not yet have a direct comparison between the high dose and exemestane, and we only have phase 2 data against anastrozole, you have to remember those old data were at half the appropriate dose. The 500 dose is clearly more effective. So the first trial, which John Robertson updated at San Antonio, should have invited him to give this talk. He knows the drug better than anybody. This is a phase 2 trial comparing the 500 milligram dose with loading, so you don't have the long pharmacokinetic problem, against the standard anastrozole dose, but only 200 patients. The primary endpoint was clinical benefit, and in fact it's negative for the primary endpoint. So you could say 500 is no better than anastrozole. However, what matters to me in a way isn't the rate of clinical benefit, but in a sense is how long we manage that woman's disease on that therapy. Because if it ain't getting worse and she can stay on it for longer, then actually I think that's an advantage. So this is a secondary endpoint in a phase 2 trial. However, the secondary endpoint of progression-free survival is clearly significantly better. It's only 2/3, a hazard ratio of 0.66 for the fulvestrant compared to anastrozole. And what John presented at San Antonio was the first overall survival analysis, which is suggesting that actually over time, not necessarily in the first couple of years, because those patients are probably less endocrine sensitive, they're progressing and dying more quickly, but this is the group we really target with endocrine therapy, those we wish to keep alive for as long as we can with hormone therapy. There does appear to be something in favor of the fulvestrant 500 milligram dose. It's a phase 2 trial. It doesn't prove it's better, but it clearly suggests, based on the other data, that it may be better than anastrozole. And so there will be a confirmatory phase 3 trial called Falcon, which is randomizing, and it's a double-blind trial, so we won't even have the bias argument. And that will be very important to give us a readout in phase 3 setting, where the fulvestrant is actually better than anastrozole, which is what the data so far, to me, suggest. Where could we go in the future? I'm leaving time for discussion, so I'll give you one case and then we can go on to a more common discussion. Fulvestrant is metabolized differently. That's not quite right. The word should be differently in there. It's metabolized differently from some of the aromatase inhibitors, where there have been problems combining aromatase inhibitors with some of the newer drugs because of a pharmacokinetic interaction. And so at San Antonio, for example, there were a number of presentations, early stage studies, so I'm not giving you the data, but a number of studies are either completed or ongoing, combining fulvestrant with other agents. Enzalutamide is very interesting. We've known for a long time that breast cancers express the androgen receptor. Those of you who treat prostate cancer as well know you're in the right session. It is a breast cancer session. But AR is also expressed in breast cancer, and this is an androgen receptor antagonist, and so there are studies combining it with fulvestrant. Could be very interesting. Two completely separate endocrine pathways being blocked. A lot of interest, of course, in PI3 kinase, and there are studies going on with BKM120 and one or two others. And, of course, we know about the emerging data on the CDK4/6 inhibitors. We've seen the phase 2 data with letrozole for palbociclib, but in fact there are studies looking at combining these drugs with fulvestrant. So this is a watch this space. Far too early. None of these drugs are licensed for breast cancer. It's far too early to say that this is a way forward, but it's interesting because fulvestrant's metabolism is that little bit different. We can look at combining them with agents, and that may come up with an even more effective endocrine therapy. So what do we do? How do we choose? First-line endocrine therapy, almost everybody will progress at some point. And we know, therefore, from the data I showed you earlier, that if they have some evidence of sensitivity, they're likely to respond to subsequent lines. But we do not have a single biological marker. You can't ask your pathologist to do a test and say yes or no, they will respond to the next line of therapy. We have to use clinical factors. And what are the choices? Well, if you've got low sensitivity, most of our patients head to chemotherapy. We can look at exemestane plus everolimus. We can look at fulvestrant. But as a pure endocrine therapy, it's probably not the best option there. And increasingly we're using chemotherapy, because this, of course, has not insignificant toxicities. But if you've got moderately endocrine-sensitive therapy, those are technically the choices, and we have no comparative data between this 500 or higher dose of fulvestrant with either of those. But given that these two are equivalent at the low dose, and we know that 500 is better than 250, I think it's a reasonable assumption, can't prove it, but it's a reasonable assumption to expect if the phase 3 data hold up from this, that actually fulvestrant at the 500 milligram dose may well be better than exemestane. How it compares to exemestane plus everolimus is a different question, both in terms of efficacy, but also in terms of toxicity. Fulvestrant's toxicity, apart from the injection, is really the same as any other endocrine therapy. Whereas we all know, those of us who've used it, when you add everolimus to endocrine therapy, you're moving into a new area of toxicities that we do not see with endocrine therapy. And I think really this is where this is probably most likely to come in at this point in time. Clearly, if the phase 3 trial shows it's better than anastrozole, it may even move earlier line. But for now, that's where I think the data really support its use. So you can come up with this sort of algorithm. Adjuvant endocrine therapy, sadly the woman relapses. Fulvestrant could be used first line there, or you may use another aromatase inhibitor and then go on to fulvestrant before moving on to chemotherapy. That's the sort of paradigm a lot of us are using as to where we want to put this drug in. So in the last few minutes,